right, it's now 12:02 a.m. and I'm going to go ahead and start with some introductions. First, I want to say good morning, good afternoon, and good evening, and welcome to the first webinar of 2024. CABO wants to welcome all the attendees in the U.S. and abroad. Thank you for joining us today. Before we begin, I would like to take a moment to share a few additional educational events we have scheduled for this year. Mark your calendars for May 11th. We have another webinar in the works with Dr. Strakowski, and those details will be announced soon. June 15th and 16th, we have our first physician-focused EMG, NCS, and NEMIS workshop in New York, featuring Dr. Devin Rubin and Dr. Jeffrey Strakowski. On June 22nd and 23rd, we will hold our technologist-focused nerve conduction and introduction to NEMIS workshop in Las Vegas, Nevada. Before we begin, I would like to take a moment to thank Michaela Pope, Abe Gardner, and the Cadwell marketing team, as well as Dr. Smith, for making today's event possible. Without further ado, I would like to introduce Dr. Joshua Smith. He has earned his medical degree at Lake Erie College of Osteopathic Medicine and completed his residency at the University of Pittsburgh School of Medicine. He is certified in neurology by the American Board of Psychiatry and Neurology, and currently practices at North Shore Neurology, UPMC, and is affiliated with UPMC Hammett. Dr. Smith is not only an excellent physician, he is a brilliant educator and mentor to many. Dr. Smith, would you like
All
to
right.
go ahead and begin?
Yeah, let's get started. So thank you everybody for kind of coming out. I'm gonna just get this share screen thing fired up and we'll get rolling here. All right, I am gonna kind of save questions for the end. I have a slide, but there is a Q&A feature. So if you kind of fill them in, we'll kind of open it up at the end. Again, this is just kind of an introduction to neuromuscular ultrasound. I'm Dr. Smith, and it's a pleasure to have you all here. I have no financial disclosures. All the ultrasound images obtained are using the Cadwell Sierra Summit machine and technology. So just to, start off with some basics, what is ultrasound? I'm sure some of you know, maybe some are less familiar, depending on your training and specialty. But all you really need for ultrasound is a probe connected to a computer and a display screen. So there's really not too much to it, but the probe is the main workhorse. It contains rows of ceramic or crystal elements that have piezoelectric properties, and that's kind of a fun word. And what it means, if you run current through them, you can actually kind of change their shape and size. So if you run current through them and they oscillate, they can generate sound waves. That also means that as sound waves come back to them, that can actually make them change shape and size, and then they'll generate electrical current. So basically using electricity, you can generate sound waves, they'll go out, they'll come back, and then the computer just interprets that. It's very important you take care of your ultrasound probes because they're quite expensive. Some of the advantages of ultrasound is, when you do an EMG and a nerve conduction study, you're really getting the physiologic function of the nerve, which is very helpful. But if you add ultrasound, you get structural information. EMG and nerve conduction study we use to determine what is going on with nerve and muscle, or maybe where the problem is, but it doesn't always tell you what's going on at that site. Neuromuscular ultrasound can also be dynamic. So you can kind of have your patients moving around. You can get dynamic information on movements or different positions or structures. Again, it's not a lot of equipment. It's also very tolerable. You'll all have those patients that have trouble maybe tolerating the full study, and maybe you wanted to do more. But as far as the ultrasound goes, it's cool gel and some pictures, so it's tolerated very easily by patients. And really, if you kind of work with your lab and wherever you are, it can be incorporated into your lab pretty easily. And again, when you have both, you get function from your EMG nerve conduction study, but you get form, you get structure, you get that extra information from the ultrasound. And who better to do it rather than the EMG, or who knows what they're looking for. There's been a lot of advancements in ultrasound. Transducers are improving, software is improving, it's portable, safe, and really it's low cost to your patient. So it's really a low cost, low risk to your patient. It's a validated form of diagnostics. There's numerous publications, A&EM, etc., guidelines and practice parameters. You can even add on, the American Board of Electrodiagnostic Medicine has an add-on certificate for ultrasound, and their billing changes, and now there's even specific billing code for neuromuscular ultrasound, although you kind of borrow these non-vascular limb studies for some other things. So again, who should be adding on this ultrasound? I think people who do EMG and nerve conduction study, whether it's physicians or technologists alike, are the people that are really good to be doing the ultrasound. I don't think it should be EMG nerve conduction and then go to the kind of radiology suite and get some pictures done. Because when we're doing our study, we kind of know where to look. We know the anatomy very well. We know the disorders we're already looking for. So who better? And you're seeing the patient and examining them. Um, an important differentiation is neuromuscular ultrasound does have overlap with musculoskeletal ultrasound, but in neuromuscular ultrasound, the focus is on muscles and nerves, less the joints, tendons, and supporting structures. Although depending on your level of comfortability, you're going to comment on those as well. You're going to see those changes, and you can add them into your reports. When you have these two things together, there's things you can expect, okay? One thing is it can help to confirm your diagnosis. We've all had those cases where you're pretty sure somebody has carpal tunnel and you're doing comparison studies and things are kind of borderline and you're pretty sure it's there. Sometimes just adding this in can increase your confidence, oh, that there is a focal change in the nerve here and that should be, pursued for treatment. Sometimes it'll give you some additional information you didn't know about. It might not be any benefit at all, but again, it's just cool gel and some pictures, very low risk, comfortable. Usually I'm doing it at the end of the study. So if they've already had their nerve conduction study in EMG, and I say we're just going to take some pictures, it's the easiest part of the test for them. Usually by then they're quite relaxed. And again, the cost is very low to patients. And then sometimes it gives you some key information or a surprising finding you weren't expecting to see at all. And maybe the patient would have left without that information. And sometimes it can also be very helpful for your surgeons. I'm going to go through some common artifacts, and I have lots of videos and pictures to come, so we'll kind of enjoy those together. And at the end, if you want me to re-review any, just put it in the Q&A. But some really common artifacts just to kind of know, because they'll be helpful for you when you're starting neuromuscular ultrasound, is tissue anisotropy. What does that mean? It just means some tissues reflect more or less sound based on the angle of incidence. So when you're holding your ultrasound probe down over the skin, tissues that have high anisotropy, if you're directly perpendicular to the tissue, they'll appear quite bright, and then you can tilt it a little bit and they'll get much darker. Tissues with low anisotropy will not change quite as much. This is particularly helpful because tendons have high anisotropy and nerves have lower anisotropy. So especially in certain places like at the wrist, where if you've never done neuromuscular ultrasound, starting just by evaluating something common like carpal tunnel syndrome is a good place to start. A lot of times you're looking in there and you're like, oh, there's all these structures and they kind of look similar. Being able to just tilt your probe, and I have a video of that to show you in order to say, okay, I'm confident that this is the nerve and these are the tendons, is very helpful. Shadowing is basically some tissues reflect almost all the sound and we can't see through them. Bones are going to be the big one. If someone has surgical hardware and metal, you'll see that too. And then there's something called enhancement or posterior acoustic enhancement. This is where you have some tissues that allow almost all the sound to go directly through them. And then actually the tissue behind them will appear relatively brighter compared to the other tissue just because the sound wave was able to go through it. This is common in simple cystic structures. So here's a video. And this, I'm basically tilting the probe up and down. You see these structures go from being light to very dark. So they have high anisotropy. These are tendons. And then there's this structure here that doesn't change quite as much. And that is the median nerve at my wrist. So that's how you can kind of quickly do that. And it shows you the differences and makes it easier. Here are some pictures. This is again my wrist, but these really bright structures, these are the bones, in my wrist, and then behind it you have that shadowing, so I can't really see through the bones, but I can actually see my median nerve kind of running right through my wrist and my carpal tunnel, pretty nice. And then this is that posterior acoustic enhancement. So this, I have a probe over the cystic structure, and then you see behind it everything looks very bright. This is more of just an artifact because these tissues are reflecting a lot of the sound and it kind of shoots right through the cyst. So everything looks kind of brighter and enhanced here. When you're doing nerve ultrasound, usually you're using linear array transducers at 12 megahertz or higher. Currently, neuromuscular ultrasound tends to have greater spatial resolution than MRI when it comes to peripheral nerves, although MRI neurography is getting more and more popular. Again, the cost of getting an MRI of a nerve versus an ultrasound of a nerve is vastly different. Also, if someone can get an EMG and a nerve conduction study and at the same time can throw the ultrasound on and get that information instead of them having to come back for an MRI is a big advantage for the patients and cost. You can view the nerves different ways. Sagittal, cross-section are the most common. Sometimes you can take multiple kind of sagittal images and actually kind of link them up and get kind of a picture of the whole nerve depending on your ultrasound machine. And then what do you look at when you're looking at these nerves? There's a lot of normative data for cross-sectional area of nerves. So when you're looking at them in cross-section, you actually you measure a cross-sectional area at certain sites, and there's a lot of normative data that's been published for that. That's very helpful, especially when it comes to entrapments, and we'll discuss that further. You're also looking at the encode density of the nerves. You can throw Doppler on and look at the vascularity. Normally, nerves are not particularly vascular on Doppler. So if you throw a Doppler on and you see blood flow in a nerve 1, is there actually an artery close to it, like if someone has a persistent median artery or something at the wrist? Or are you just seeing increased vascularity from something going on with the nerve? And that can be a clue to severity of a problem or a clue that something is going on that increases nerve vascularity. Mobility, I think our colleagues in physical and occupational therapy have done things for years, nerve glide techniques. If you send them to occupational therapists for carpal tunnel, there's doing these exercises to try to mobilize nerves. When you start doing ultrasound, you realize that they do move around quite a bit, especially at certain areas and structures like the wrist, your median nerve. When you kind of open and close your hand, it's moving above and below tendons quite easily. So they're not as fixed structures as sometimes you think. And mobility can be normal or decreased in some certain situations too. And again, surrounding structures, is anything abnormal present contacting the nerves or not? What happens with abnormal nerves? So normally nerves, and I'll have some pictures, appear kind of like these bright honeycomb structures. You can actually see little vasicles in them. When they become entrapped or injured, they tend to become edematous, like most tissues, so tumor, and then they'll actually become enlarged, especially at areas beyond entrapment, or if they get inflamed. When they become enlarged, it'll get to a point that sometimes you'll start to lose the fascicular architecture and you'll have decreased echo density. So they go from being kind of bright honeycomb structures to kind of swollen, darker structures. That's generally what you see with nerve problems. You can see tumors in or around the nerves. Sometimes you have situations where I have diffuse nerve hypertrophy. So the cross-sectional area of all these nerves are very enlarged, and I have a video of that a little later. Again, vascularity using Doppler, and as discussed, the mobility changes. So a lot of times that's kind of dynamic. You're having them kind of move their wrist or hand, elbow, knee, etc., or even their head and neck and shoulder muscles if you're looking at a plexus. So these are just some pictures of normal nerves. So here is a median nerve at the wrist. I hope you can see the laser pointer just fine, but you kind of see how there's this kind of white lining inside of it. That's just the connective tissue in the nerve. And then the dark spots are actually kind of the nerves themselves. Those are the dark fascicles. So people say it kind of looks like a honeycomb. And this is, again, my median nerve in a sagittal view coming through. So you kind of see the fascicular structure and then the brighter connective tissue surrounding the nerve. Here's a video of an abnormal nerve. This is actually the median nerve in the forearm, and we're going to follow it up into the wrist. And you see here all of a sudden, oh, this nerve looks significantly different than the other one. I'll go back because I just want to make this point. So here is kind of the healthy nerve at the wrist. And then here is a nerve. This is a patient who has carpal tunnel syndrome. That was quite severe, and they actually have like a little piece of scar tissue in their nerve too. But you see how you don't really see that connective tissue inside. It's enlarged. So if I measured it with cross-sectional area, it's going to be big. But you can tell that this nerve doesn't look like the other one. It's swollen, especially when nerves get pinched. Behind the pinch, they swell up and get big. So, what are some simple nerve ultrasound uses? First kind of uses that came out were for entrapments, and common ones kind of median nerve at the wrist, ulnar, peroneal, radial, tibial nerves can be assessed. You can even see the sural nerve. I had a patient recently that had had an ankle surgery and then developed a sural mononeuropathy just on location, and you could actually kind of see on the ultrasound where her problem was. It can be helpful in traumatic neuropathies, as in, is this nerve completely transected or not? Brachial plexopathy. And generalized neuropathies, it's helpful, especially when you have a patient maybe that you're considering they have an immune-mediated neuropathy with demyelinating characteristics. Those tend to cause hypertrophic neuropathies that are kind of rather diffuse. So CIDP, you can see proximal changes in some of these nerves on ultrasound, and there's even some papers showing you can increase diagnostic sensitivity for CIDP by adding ultrasound of even just like the median or ulnar nerve in the arm, and then adding C5 and C6 roots in the neck, which are actually pretty easy to see. In motor nerve disease, it can be particularly helpful. And the reason it's quite helpful in motor nerve disease is one, you can see muscle changes, but two, it's very good at fasciculation detection. So when it comes to fasciculations, we know that our needle EMG, when we puncture that muscle and record, is better than kind of the naked eye or palpating a muscle. But when your needle's in there, your recording area is quite small. So depending on where you are in the muscle, they're much larger than your needle. You're only recording from a small area. Ultrasound lets you really scan a muscle quite easily. And maybe even sometimes I'll use it beforehand to kind of pick muscles that are fasciculating, and those are more the ones I want to needle. And then you can cut down on how many kind of needle pokes your patient has to go through, especially when you're dealing with that kind of diagnosis. And then you can use it for procedure guidance. You can guide for injections. You can also guide for needles. Some people will use it if they're going to be needling the diaphragm muscle and they want to make sure they're going to be at the correct depth, or they could even watch kind of the needle go into the musculature to record. I tend to use it just to measure how deep I'm going to have to go. And then I have an idea when I'm going with my needle how deep the diaphragm is going to be. I'll go through some cases now regarding nerves, and then we'll kind of talk a little bit about muscle ultrasound as well. These are just kind of common introduction things and just kind of show some of the benefits of adding neuromuscular ultrasound. So this first one is a 50-year-old male. He's left-handed. He has a numb left pinky and part of his ring finger. You do your nerve conductions. He has an absent ulnar sensory response at digit 5, borderline low amplitude ulnar motor response, and you really try, but you really can't find any focal conduction block or slowed conduction velocity. And then you do your EMG and you see some chronic neurogenic appearing motor unit action potentials in the FDI, FDP, maybe even if you want to do FCU and some other ones. But by the time you're done with the study, maybe even you threw in a medial antebrachocutaneous because you're really worried about kind of lower cord, and that looks good. And then you're kind of unsatisfied when you say, well, it's definitely an ulnar nerve problem, but I'm not exactly sure where it is. If I roll the dice, it's probably going to be at your elbow, but did you want to commit that patient to a surgery or not would be the question, right? When you can't be 100% confident. So I have some images here of a patient. So this is actually the ulnar nerve in the forearm, and it follows the ulnar artery at that time. And at this point, as I'm scanning up this patient's forearm, I'll tell you this area is very normal for an ulnar nerve in the forearm. I can also see the little fascicles, the structure. It looks very happy. However, when I get up into the cubital tunnel of this patient, the nerve starts to become quite abnormal. This has a significantly increased area, and what you're seeing here actually are the two heads of the flexor carpi ulnaris. Remember, your true cubital tunnel is made by the fibrous band as those two heads kind of come together and form the bulk of the muscle, and it kind of emerges under that. So adding on ultrasound, you're able to localize it quite well. And now I have a little video of that for you as well. This first one is actually my kind of ulnar nerve jumping in and out of my cubital tunnel. So here's the nerve, flexor carpi ulnaris muscle, and you're going to see it come up and just kind of boop, pop through the fibrous band. And my ulnar nerve is pretty happy and not diseased as far as I'm aware. This is the patient. So you kind of come up, here's the ulnar nerve, flexor carpi ulnaris. You're going to track it up, and this is significantly abnormal. So, by adding an ultrasound to this patient, you had proved ulnar mononeuropathy, and now you've also helped with localization. And there are papers that suggest that this does add some sensitivity for localization if you can't quite get a conduction block. I kind of prefer it a lot of times to inching for the patients. And there's sometimes you get surprised by what you see. You really think, oh yeah, this is going to be truly cubital tunnel, but it's at the epicondyle or retrocondylar, or you find something else kind of odd at the elbow. So case number 2, you have a 45-year-old male. He has left hand pain, kind of paresthesia, and he comes in because they're concerned he has carpal tunnel syndrome. You do nerve conduction studies, normal median motor and sensory responses. You do mixed pulmonary responses. The latencies are both 1.9 milliseconds. They're pretty equal. EMG is normal. You even put him through an APB examination, and that looks pretty normal. But he's telling you it kind of really hurts, and you're kind of looking at his wrist, and you're thinking, well, I didn't really find anything on your nerve conduction study, but why don't we throw the ultrasound on and just take a little look? So here is this patient's median nerve at the wrist, and it looks pretty normal to me. I can see the fascicular architecture. I can count many fascicles in it. If I measured it, the cross-sectional area is normal. But there's this structure here that is at his wrist on this side and not the other side. And this is a muscle that is intruding into and around his carpal tunnel. And what he ended up having was a reverse palmaris brevis, which is just an accessory muscle you don't need. It's usually located in the forearm with tendons into the wrist, but for him, the muscle bulk was in his wrist. So he was developing a kind of pseudo compartment syndrome of his wrist. So he just used it and it would kind of hurt more. He ended up having this taken out and his symptoms went away. And you might say, well, this isn't really a nerve problem, but I would have never known that there was this abnormality. I don't know if he would have got an MRI of his wrist ordered. So this is an example when you find something that kind of surprises you, but it ends up helping your patient out in the long run. And again, it's not very invasive. Case 3, you have a 33-year-old male. He's got some right leg pain. He's coming to you in clinic. He already had nerve conduction study and EMG. That's normal on that limb, but he has a bump over his right thigh, and he looks at you and he pushes on it. And he says, it's numb and it hurts when I do that. So you'll recognize this picture. So this is a cystic structure in his thigh. And what I'll tell you is this has continuity with his nerves. And what I didn't tell you is that he has NF type 1. So he had a neurofibroma basically that had become enlarged in one of his cutaneous nerves of his thigh and was causing him discomfort. A lot of times, if these tumors don't really destroy the nerves, these patients with NF can have a lot of pain and discomfort in kind of nerve distributions, but your nerve conductions can still look pretty normal. And unless they really have axon loss, your needle exam is going to look good, and usually they don't get conduction block from these things. But ultrasound, you can kind of throw down pretty quick. You can look over it. You can almost do it to Nels. You can kind of push on it and you say, yeah, that's your problem. He opted to not have this kind of removed. But another kind of quick example of, even in the clinic, I kind of wheel this thing around from time to time if I'm seeing somebody. Next case is a 65-year-old female. She comes in because her daughter was diagnosed with a nerve condition and she thinks she might have it too. She denies any numbness. She says she has weak ankles. And when you examine her, she has obvious bilateral foot drop. She's not wearing any braces. She says, I've just kind of always been this way. So, you immediately have your suspicions. And what I'll say is this is actually her median nerve here, really close to her wrist. And these are very big, enlarged fascicles kind of throughout this whole nerve. This doesn't look like a healthy nerve. And then here is actually the nerve coming down in the forearm. And diffusely, this nerve, anywhere you look at her median nerve, going all the way up her arm or ulnar nerve, it's very enlarged with really big fascicles. So for this patient, I just proceeded with some genetic testing, and she, of course, had a PNP22 duplication and CMT1A. But, they tend to have diffuse nerve hypertrophy, just like when you do pathology of those nerves and they have the onion bulbs and they look big on the ultrasound as well, rather diffusely. In autoimmune nerve conditions, it can be kind of more patchy. But there are some patients, that you can maybe skip the nerve conduction study with a really strong family history and go genetic testing depending on the availability. Case number 5, kind of similar to the first case. It's a 50-year-old female, comes in with left pinky finger numbness. She has a history of an elbow fracture 10 years ago, and already you're like, oh yeah, tardy ulnar palsy. That's what's kind of jumping to mind, right? Maybe she's developed some scar and some bony abnormalities there, and that's slowly changed and is entrapping her ulnar nerve at her elbow. And then you do nerve conduction studies, loss of amplitude, digit 5, sensory response, dorsal intercutaneous response as well, motor conduction block across the elbow segment, like slam dunk, ulnar neuropathy at the elbow. You even inch it, and it's kind of at the medial epicondyle, and you're like, oh, maybe she should be sent for a transposition of her nerve. Your EMG kind of confirms chronic neurogenic motor action potentials in multiple ulnar innervated nerves. So in this patient, here is actually her medial epicondyle and her olecranon. And then here is her ulnar nerve kind of right at that structure, right next to the medial epicondyle. And I'll draw your attention to this big dark structure. And you might be tempted to say this is just a really big abnormal fascicle. But when you really look at it, this structure is kind of abutting into the nerve, but it is not nerve. And what this actually is, this is an intraneural ganglion cyst at the elbow. So, there's no way with you just doing nerve conduction studies that you could have told the surgeon that I think they have a ganglion cyst at their elbow. And what ends up happening is you have an articular branch into the joint, just like you could get ganglion cyst. Baker cyst is just big ganglion cyst behind the knee, at the wrist. One of the articular branches that goes into the joint ends up getting dissected synovial fluid, and then it fills up and it compresses the nerve. This is important because if they did a transposition on this patient and just tried to move the nerve and they didn't drain the cyst and ligate the articular branch, they would still have the problem. They wouldn't be any better. So this is an example of when it really kind of gave you some more information structurally that's really going to help if you're going to be referring your patients for surgery. The last nerve case, this is a 62-year-old male. He has a history of peripheral neuropathy due to diabetes, history of right carpal tunnel, status post-release like 10 years ago. His diabetes was pretty mild then. And now he's developed kind of similar symptoms in his left hand. He has a Tinel's at his wrist. He has nocturnal symptoms, and he says, it feels like I'm getting carpal tunnel on that side now. His neuropathy is pretty bad. His diabetes is not very well controlled. And when you do nerve conduction studies, what do you see? Well, the median and ulnar sensory responses are absent. The radial sensory response is low. The right median and ulnar responses are both borderline low, slightly prolonged distal latencies. You try to do some comparisons, but there's a lot of peripheral nerve problem going on, and it just becomes very difficult for you to be very confident electrodiagnostically that there is carpal tunnel on that side. So how could ultrasound help in this case? Well, one, you put it on, and then you can measure his median nerve at his wrist, and it is significantly enlarged. Now, nerves at areas of compression tend to be a little bigger, and there's some papers saying, diabetics can have slightly bigger nerves, but it's very, very, very minimal. And then another thing you can do is you can measure in sagittal. So what you can see, especially with compression and sagittal, is you can actually see beaking of the nerve. So the nerve here is coming into the kind of carpal tunnel. Here's even the transverse carpal ligament, and you can actually see it be pinched. And I even did some little measurements. So when you can see a pinch like this, it is pinched there. So with the ultrasound now, I can be very confident and say, I don't know if they're even going to want to do a local steroid injection. You already have this neuropathy, but a release would probably help with some of the symptoms from carpal tunnel syndrome. Now, it's not going to help with this peripheral neuropathy, but you can maybe help increase the confidence of sending him to a hand surgeon who maybe will want to intervene versus if they just saw the nerve conduction study saying, well, there's a neuropathy and I can't be sure, they may not intervene for this patient. So the beaking can sometimes be very helpful for these patients. And then here's just kind of a video of his nerve kind of coming up. And you can see, actually, this is the transverse carpal ligament. I'll kind of run it again. Here's the nerve in the forearm. It actually looks pretty good. You're tracing it up and it becomes enlarged and abnormal, and then actually a little smaller after it gets past that point of compression. So even when you see that in your kind of cross-sectional view, you can tell that there's going to be a point of compression. They're probably going to be beaking. You just turn it, take your picture sagittal, and it gives you help and helps your patients out too. We'll switch now to muscle ultrasound. Often you're going to use a 5 to 7.5 megahertz kind of probe. It depends on how deep the muscle is, And most probes are ranged probes. So the same kind of probe head that I'm using for the nerve is the same one I can use for the muscle. It's just a dial and I can change the megahertz. Sometimes I'll still leave it at like 14 to 16 if I can still see the muscles pretty well. So it depends how deep it is. The deeper structure you need, you're going to want to drop down to lower frequency and it will kind of brighten them up, and then you can change some other things. Muscles tend to have a starry sky kind of appearance. Basically, the muscle fibers themselves are dark and the connective tissue again is bright. And you can look at an sagittal view, you can see paramesial lines. It depends on the muscle, but really it's a nice way to screen the musculature. What are you looking for when you're doing muscle ultrasound? You know, you can do muscle thickness measurements. There are some people working in neuro data for that. I like it for side to side. You know, somebody comes in, it's very helpful if the problem is just on one side. You could just measure the thickness at rest of the biceps on this side, biceps the other side. You can go back and forth. Um, you can look at the muscle echogenicity or echo texture pattern. Unlike nerves again kind of start bright and vesicular, and then as they get that abnormal, they become darker and bigger and swollen. Muscle tends to get smaller and brighter as it becomes more abnormal, especially if it gets fibrofatty replacement, right? Then it's going to get kind of brighter and brighter because there's just more connective tissue and less musculature. It also allows for a dynamic movement, so you can see contraction, you can easily see tremor. Fasciculation detection is very good with muscle ultrasound. And again, just because the area you can scan, there's papers showing that muscle ultrasound is more sensitive for fasciculations than EMG. And we know, again, EMG is better than just our kind of eyes in our clinical exam. And then sometimes you can see fibrillation potentials and even like myokymia and stuff. So here is a left biceps brachii that's pretty normal, and you can literally see the two big heads and the connective tissue running through it. And if you squint, you can see the starry sky. I say here it is in another view, more as a sagittal view, and you can just see the muscle fibers kind of running this way. And again, this muscle in this patient was normal and it wasn't too deep, so I just left the frequency kind of pretty high because I could see it pretty well. Here's abnormal muscle. So this is a biceps brachii of a patient. This is significantly abnormal. So this looks healthy. This does not look healthy. This is the subcutaneous tissues. This is actually the muscle. It's all kind of bright and it looks angry and mad to me. Pattern recognition, like with anything, is part of this. But that's just a good example of a quite abnormal muscle. I have some videos now. Here's just kind of a normal video of a muscle at rest. It's not moving unless you tell the patient to. She's actually a nerve down here. But you can see it at rest that's happy. And the reason I showed you that is then here's what fasciculations can look like in a muscle. And there can be kind of more or less, but you can literally see them. Again, I'm seeing the whole kind of cross section of this triceps muscle. So you get a lot more information. And then here's even kind of more frequent ones. Here's also example. This is a biceps brachii, but if I were to needle into this patient, you know, I could needle the biceps, or I might want to needle into this brachialis. It looks more abnormal with the echo texture, and I'm likely to, one, be able to record fasciculations, but also see more chronic neurogenic action potentials. And if you're looking for motor nerve disease, you know, you want those kind of things together. So this could help say, you know, brachialis is not something I commonly needle, but maybe in this patient, a brachialis would be more useful for diagnosis than the bicep brachii, depending on where you poke it. Muscle ultrasound uses. It's helpful for muscular dystrophy, congenital myopathy, inflammatory myopathy. You know, if you see kids, I don't see many kids, but I do from time to time do pediatric examinations, sometimes even starting with an ultrasound to kind of get a feel for what is going on or not going on. It kind of is comfortable. It's fun. They can be looking at the screen. You can say, hey, can you move? It's a little more interactive and it kind of relax them a little bit. Sometimes even adults, I do that if they're particularly nervous. I also really like it for diaphragm ultrasound. There's lots of good papers on diaphragm ultrasound at bedside. Fasciculation detection, again, I really like it for, you know, motor nerve disease patients. And the neuropathic echo texture changes too. Sometimes you can ultrasound and you can see, well, all the muscles distally in the leg are quite abnormal, and maybe they have a distal length dependent, at least in part, motor neuropathy. You know, sensory motor is going to be more common, but So some muscle cases. This first one is kind of a diaphragm case. This is a 55-year-old male. He basically says one night he woke up in the middle of the night and he could not breathe laying flat. He just woke up, he felt very winded and short of breath, and he's been sleeping in a recliner since that time. Um, Again, he has trouble laying flat, exercising, but otherwise he feels well. Um, he's had some chest x-rays showing some abnormalities of one of his hemidiaphragms, and he has EMG and nerve conduction studies scheduled in a month. So I saw him, had some time in the clinic, and I said, well, why don't I just get the ultrasound and kind of throw it on to get an idea of what's going on. So here is a ultrasound kind of looking between the ribs. So here is actually a rib, here are intercostal muscles, and then this structure here is the diaphragm. Sometimes you'll see kind of light, dark, little light in the middle, dark and light. So this is the diaphragm. This is on his side that is good on the pictures, but even if I didn't do it, you can measure the resting thickness of the diaphragm. There's normative values for that. You can then have a patient breathe in, take a deep breath in, take a deep breath out. You should see it kind of thicken between those two things by at least 20% to be normal. You can also use some different probes if you kind of want to put it under their rib cage, and you can actually measure the excursion. This linear probe is the same one I use for the muscles and the nerves, so I'm keeping the same probe on my machine and I can get all these pictures. Versus his other side, his right diaphragm is actually this skinny, thin structure here. So there's light, dark, little light, dark. This is a very atrophic and quite abnormal looking diaphragm. Even if you didn't have the x-rays, you'd be like, should probably do some studies on your right diaphragm, versus if you put the ultrasound on and things look very normal and it's been some time, maybe you really don't want to do phrenic nerve studies or diaphragm. This can help you say, yeah, we really should do these studies. And it basically showed that I couldn't get a phrenic motor response with either the common ways to record from that. And when I needled it, all I could get out of his diaphragm was fibrillations and positive sharp waves. Here is another case. A 65-year-old female comes in for leg weakness. She had some evaluations in the past, and they thought maybe it's just some age-related changes. They thought maybe her knee was bad because she feels like her knee is unstable, and it kind of gives out, but she's not falling, and it's been going on for like 2 or 3 years, slowly, she thinks. And otherwise, she says her hands and arms, everything's fine, but that one knee just feels unstable. Quickly on your examination, though, you're like, your quadriceps is pretty weak on the left side. And she gives you pretty good effort. So I just went and I kind of slapped the ultrasound on there. So here's the thigh, and then here's subcutaneous tissue, and then this kind of bright structure. This doesn't look like normal muscle. Her quadriceps is quite significantly abnormal. And then, you kind of think of some things with asymmetric quadricep weakness. So I went ahead and I kind of threw it on her proximal forearm. Here you can see the flexor carpi ulnaris muscle and then the flexor digitorum profundus muscle. And you'll notice that these deep finger flexor muscle is abnormal, kind of has this brighter signal. So that's some abnormal muscle. Um, and then what ended up happening is I kind of did some needle examination on her quadriceps. You kind of find maximal myopathy, things distally, a little more neurogenic proximally. And then I even went up and I kind of stuck the flexor digitorum profundus, although she really wasn't that clinically weak there. And it showed some myopathic abnormalities. Of course, the patient went on to have muscle biopsy and a diagnosis of inclusion body myositis. So sometimes ultrasound scanning could help you pick nerves, depending on your level of comfortability. Even if they had a little finger flexor weakness and you were poking around and you accidentally poked into really the flexor carpi ulnaris muscle, it's going to look pretty normal, versus this neighboring muscle is quite normal. Inflammatory myopathy is notoriously kind of patchy and abnormal. So this can help guide you, one, to either kind of pick where to needle or even to pick where to biopsy. This will be the last case. This is a 59-year-old female with proximal muscular weakness. She has a CPK elevated at 5,000. So you're impressed by that. They had an EMG elsewhere showing myopathic motor unit action potential descriptions, right? Low amplitude, short duration, polyphasic, early recruiting with increased insertional activity. And they mentioned fibrillation potentials. So you're thinking, okay, so this is probably, an irritable myopathy or a myopathy with muscle membrane instability, degeneration or necrosis. They had a vastus lateralis muscle biopsy. Showed some chronic neurogenic changes and mild myopathy, but really wasn't diagnostic for any particular thing. And with the CPK that high, you're thinking, is this muscular dystrophy or maybe this could be inflammatory myopathy? So they come to you for another opinion and they're questioning if they should get another biopsy done. Because they said, well, maybe you just have a muscular dystrophy. We didn't really see any inflammatory myopathy. When you examine the patient, they're quite weak, and they say, "Yeah, I've probably gotten weaker." And you'll recognize this picture, but this is just the ultrasound I did really quick with their biceps brachii, and it's significantly abnormal. I didn't even reneedle this patient. I just kind of said, sometimes with the lower extremities, you run into problems where you have a patient in their 60s and 70s, and they probably have some stuff in their back and radiculopathy, and they're going to have some chronic neurogenic changes. And in the back of your mind, inflammatory myopathies are patchy. His patient undergoes biopsy and is diagnosed with necrotizing myopathy. Um, Ended up, they were in a wheelchair when I saw them. They've been on IVIG and CellCept for about 6 months, and they are walking again, but they're still pretty weak. So, the ultrasound is quick. You can have it in the clinic or the EMG lab. And for this patient, it kind of just helped me confirm suspicion and then also just scan and say, this muscle is this strength. MRC, it was like 4 minus, significantly abnormal. I want the biopsy from here. And you get your diagnosis. So these are some of my sources. Really good kind of review paper, really good review books. You'll recognize Strakowski in some of them. Cartwright is another big name. I'm going to open it up to questions now. So I am going to try to figure out this Q&A thing. I'm going to leave the lecture open in case you want me to kind of go in and go through stuff.
Dr. Smith, if you click at the bottom, the Q&A, there are 3 questions in the queue for you right now.
Okay, I see it. I figured it out.
Okay.
So first one I have is from, I can't see your full names, but it says, hello, Mr. Smith, great webinar. Thanks again. It's about the coloroid features, the Doppler ultrasound for usage and somehow ineffective, especially in nerve and so on. So, for adding Doppler on, I think is quite helpful. Sometimes you're looking at structures, like I even had a patient early this week who came in for a carpal tunnel, but they also had a ganglion cyst in the wrist on the back, which didn't have anything to do with their carpal tunnel, but it did cause them discomfort. And you could see the cyst structure, but it was really close to the radial artery, and you could throw on the Doppler and I could delineate where the radial artery and the ganglion cyst is. And those dorsal ganglion cyst tends to like to be right up against the radial artery. It is also nice, like ulnar at the wrist. Some people can get stuff like behind the knee, like they could get a pseudoaneurysm or an overt aneurysmal dilation, and you kind of see the structure and you're wondering, is this vascular or not, depending on your comfortability. I think having the Doppler is just a click to throw on to, is this a vascular structure or not? A good proportion of the population has some abnormalities when it comes to their median nerve at the wrist where it can be bifid, and that's not a problem, but some of them actually have a persistent median artery. So they have an artery running through the wrist as well, which really in the hands of a good surgeon shouldn't matter. But sometimes I like to make note of that. Hey, just, there is this extra artery running in their carpal tunnel. And there's some patients actually about if they have that, they can actually get thrombosis of the artery and get in a kind of an acute carpal tunnel. That doesn't make a lot of sense. So I like the Doppler just for proving vascularity or not, or you're seeing a structure and you're very certain it's an artery and you just want to prove it. You can throw the Doppler, take a picture and be like, yeah, that's an artery. The next question says, so I'm just going to say answer live. So we answered that one. Is there any application of this for radiculopathy? Radiculopathy, it's not going to be super helpful for. You can see some of the nerve roots on ultrasound, but again, with the discs and it's in the spinal canal, I'm going to not be able to really see through the bones into those structures. Now, if somebody has overt avulsion of some of their roots, that can become quite abnormal. And then you can kind of see that. So that's more helpful in like a traumatic upper trunk plexopathy. You can see if there's overt avulsion, right? Because if you have somebody with an avulsion, how long do you want to wait before sending them to like a nerve surgeon or for like tendon transfers and evaluations like that? probably sooner rather than later because it's not going to get any better. Is neuromuscular ultrasound used in practice for the pelvic floor? Yes, it can be. It depends on your comfortability with those patients. A lot of times when you're looking at the pelvics or even like gluteal muscles, or maybe you're wondering about like piriformis kind of stuff, you're going to use, and depending on how large your patient is, that can be a problem too. So those deeper structures can be tougher, but you can use probes with lower megahertz and you can see a little bit deeper. I obviously don't do a lot of stuff with the pelvis, like deep pelvic structures. I'll leave that to the ultrasonographers, use like transvaginal stuff. But you can definitely see those gluteal structures pretty nice, or the sciatic nerve. You can easily track the sciatic nerve. It's quite large and easy to see.
I think we missed one above that.
I did. There's more coming in. I see it. I'm
Yeah.
gonna answer live about pelvic floor done. I wonder if you can give an impression of the extent which is neuromuscular can replace EMG in practice. I'm a nerve and not an EMG, or wondering how neuro could expand the scope. So I really do not think that ultrasound is going to replace EMG or nerve conduction studies because they give you different information. I could see a carpal tunnel syndrome on ultrasound and get an idea about it, but I don't really know if there's conduction block. And if it's within weeks, I'm not really going to see muscle architecture changes. So I don't really know if it's denervating. So sometimes you can see abnormalities, um, but it's not as helpful to tell you severity or type of pathology. I really think it's an additional tool you have to add on. I really think they help your patient both together. Um, there's been a few circumstances where I have somebody who was they absolutely had carpal tunnel syndrome. They absolutely were not going to do in a needle examination. I said, well, I can at least localize and I could track your median nerve up the rest of your arm to make sure it's healthy. I can't tell your surgeon how bad it is. If they have chronic denervation, you'll see the muscle changes. But I really think it's an addition. Um, Also, it's not just physicians that would have to do the ultrasounds. Technicians can be trained in it too. There's a lot of large university settings where they even have their technicians kind of trained for the ultrasounds. So, they're doing the study, looks like carpal tunnel to me. The other things look good. I'm going to take maybe just some limited pictures at the wrist in cross section sagittal, and then also take some pictures in the forearm and kind of go from there. So I think it just adds information. I think they work best together. I don't think one's going to replace another. I also think depending on where you work, I work in Pennsylvania. So, we even have, physical therapists are boarded to do nerve conduction study in EMG. There's other people that are doing it. And if kind of physicians and experts in neuromuscular don't really take the reins on this, I think you're going to have a lot of people kind of using the technology, and maybe some of it is going to be more for billing, and they're not maybe the best person to be doing these studies and tests. So if that answers that question. Say cancel. Okay. Resources for normals of the cross-sectional nerves. I can send you some stuff. Wake Forest University does it. If you're really interested in this, they have a really, really good neuromuscular ultrasound kind of review course. It's like a few days, and they'll share that data with you. Mayo Clinic also has their own. They're pretty close to being similar, um, and you can even like kind of Google those, or even in textbooks, they'll kind of list them, and you can use them. And those are kind of being updated overall, but a lot of people use Mayo or Wake Forest. Um, any advice and reps on neuromuscular ultrasound billing? Yeah. So for billing, what I basically do is there is a code that is for a neuromuscular ultrasound. You have to take pictures and track the nerve through the entire limb. So sometimes I'll do, like, if it's just carpal tunnel syndrome and I just want to know at the wrist and then the forearm, do things look pretty good around the pronator teres, like common other entrapment sites. I won't do the full study, but there is a code specifically for that. Otherwise, what you end up using a lot of times if you're doing a limb is a non-vascular. You can do a complete or non-vascular limited. Complete, you really have to comment on the bones, the arteries, and other structures. If you do a limited, you can just comment on kind of the nerve or the muscle itself, and you can bill that way. So it's a non-vascular limb limited. And then if you do it on one limb and another limb, then you bill it twice. And if you're going to do it the same day as you do EMG and nerve conduction study. I don't know what your practice is. Like some people will also do a full consult that day. The ultrasound code, you would add a 59 modifier. So it's an independent separate study that was done. And then you could actually do it and bill it on the same day. What instruments are using in your clinic? So I use the ultrasound equipment associated with Sierra Summit and Cadwell. So mine is integrated into my EMG. So I'm doing the EMG on the machine and then I click a button and the probe's attached to it and I just go and I do it. Right now I have one machine with it, so sometimes I wheel it around. When I was in fellowship, they had a GE ultrasound that was just like a separate ultrasound machine. That you kind of just talk with your institution, or if you have the availability and you can add more ultrasound onto machines. I think Natus also has like a tablet ultrasound that you can kind of add on to their stuff. And for the Cadwell, it also has the reporting feature, which is kind of nice for me. So that's good. So that's what I use. What resources do you recommend for finding Wake Forest and Mayo? You can kind of use theirs. If you go to any of the big conferences, generally things are the same. You could also kind of collect your own if you really wanted to. So in the pediatric, there's not really great normative data on, although some people are working on it for kind of the pediatric nerve sizes necessarily, just like there's kind of limited for even nerve conduction a lot of times, especially when they get much younger. In the children, a lot of times it's really nice to be able to throw it on and see if, the nerves are really huge, or what is the pattern of changes in their musculature. Is it dystrophy dominant? Is it kind of patchy? Are there certain muscles that are over other muscles? Entrapment, you'll still see enlargement at entrapment sites and pinching, and that can give you a clue. Or if it's traumatic cases, you can see if a nerve is transected, and whether or not it's transected is up to how your ultrasound kind of works. CPT code for nerve ultrasound. I have them listed. I have them on a spreadsheet. I don't have them memorized. I think Cadwell actually has like a little thing that Mary could probably get out to you that actually lists the common one. But if you're starting very limited and you're not going to be commenting and doing the full nerve evaluation, I would do limited limb non-vascular is what you'd use for each limb. So if you did multiple limbs, you'd bill it multiple times. And that's what I'd use for that. Location for evaluation of ulnar nerve at the elbow. So at the elbow, I evaluated at one in its whole continuity, but specifically there's values for kind of at the cubital tunnel or the distal elbow, at the medial epicondyle, and then just proximal in the retrocondylar groove. Median nerve entrapment and ulnar nerve entrapment were kind of the first things studied. So there's kind of just more about them, but there is different norms for each of those sites. So there's actually kind of 3 different ones. They're all pretty close, but you'll usually know by your abnormalities. Is ultrasound? Yeah, you just use the codes. Again, it's not very expensive for the patient. So if you're looking to add a bunch of like money on, and that's your goal. It's probably not as good as just doing more nerve conduction study EMG, but it really is beneficial to your patients, and really for the comfort and cost, it's so little. And I think most of us are here for our patients, So to be able to kind of throw this on, get some more information, especially if it's going to be surgical, non-surgical, biopsy, genetic testing, not genetic testing, I think it adds a lot without being too expensive. And it really doesn't take too long either. Once you get good at it, you can take your pictures, the patient can go, you can analyze them later. A lot of times I do it on the fly because I kind of just tend to do my own. But it is reimbursable. And now there is a specific code, and it tends to bill a little more if you do a full evaluation of a nerve and a limb. My question is, what is the role of neuromuscular ultrasound in eye, and you will not be performed because of artifacts? So I like it in the ICU for diaphragm. Acutely, there's not going to be too many changes that you're going to see in musculature right away. I'd say one place that can be helpful is if you have somebody that's laying there, and let's say you are in an ICU where with filters and a 60 cycle, you really can't get good nerve conductions. With our newer machines, we're actually pretty lucky. We can do pretty good in our ICUs. Before it was like we'd come in there and I'd be like, I can do motors. I can't get any sensories ever. I can't really get F waves. I can't do H reflex. and I can just do motors. But in people who have inflammatory autoimmune neuropathies, they tend to have enlargement, and that includes AIDP more so than axonal Guillain-Barré. So maybe you do have a patient and you're really suspicious they kind of have Guillain-Barré. We had a patient a couple months ago who was a transfer for an outside hospital for cardiac arrest, and we were seeing them for prognosis under the neurology service, but they were like very kind of dysautonomic after their arrest. And then the family story was 3 weeks of getting very, very weak before they arrested. So we were a little suspicious that they maybe had AIDP and their dysautonomia is why they arrested. And I was on the weekend, so I threw the ultrasound on. His vagus nerve was a little big. Some of his roots were actually a little big. And then we got a little more aggressive and we did kind of the full study. So I'd say in that it can be a bit helpful. I find it helpful for diaphragm, like if the ICU doctor really wants you to needle a diaphragm, I'm more comfortable knowing how deep it's going to be in the patient with the ultrasound. I tend to not do full ultrasound guidance, but I'll put it on, I'll measure the depth, I'll know about how far my needle's going to go. So that's why I kind of like it too. Performing seems very enjoyable. I do enjoy it. It's easy. The patients like it. Even if they don't know what they're looking at, you can kind of point stuff at the screen. It engages them a little more in their test. And I think maybe if that's the last thing that's done and not the needle, they kind of leave a little more, happy with their study. Ultrasound for guidance, LP guidance, and or for trigger points. So some places do use the ultrasound to guide their lumbar punctures. I kind of tried it. I did lumbar punctures for so long without it that I just found it a little tedious. Some of the trainees kind of like it. They'll just use the ultrasounds that are in the ICU or something, not the one that we're using for neuromuscular. But you can put it on and then you can get a good idea of, okay, well, here's their interlaminar space if you're going to kind of go off center a little bit, and it can give you a little more information. You could watch it guided too if you really wanted. I never really did that in my training, so I just tend to do the lumbar puncture kind of the old way. And in the ICU, you kind of have more freedom to do that. For trigger points, it can be helpful. Even some doctors, for Botox, when they would do Botox, you'd kind of do the needle guidance. The needle would be in, you're doing EMG, they'd activate. Yep, I'm in the muscle I want to get in. They're doing this movement, and you shoot it in. And then for the trigger points, it does help you know that your needle is in the muscle and where you want it to go. You can actually see it in the muscle because, sometimes you might have a bigger patient and maybe their landmarks aren't quite as simple as you would like. Maybe even their form, maybe it's a really muscular and he just has a huge forearm and you're looking and you're like, oh, it's all just kind of one big muscle. It could help kind of increase your confidence that your needle is where you want it to be. For trigger points for like myofascial pain and stuff, I'm really not sure if there's any papers on that you can like see the trigger points or more muscle change at those points. That's something I'm not aware of myself. Let me see. Okay. Are there standards for image contrast brightness? It's more of what you're comfortable with and you keep it consistent. Struggling with darker images, you can, like on your machines, like you can increase the gain. So when you're doing it, the brightness and darkness is just by the machine. So the machine has generated this to be what it looks like. And most old ultrasound machines, you'll see on the side, they have all these little slidey bars and you can slide a couple of them and that will kind of brighten up a segment of it. Now, a lot of times it's just a knob that you kind of move up and down and you can adjust your gain to make it brighter or less. And even a lot of them have like artifact kind of reduction stuff in it. So when you start, you'll kind of develop your comfort and you can make them a lot brighter or less bright depending on what you're looking for.
We have hit noon. Are you okay continuing to answer a few more questions for
I'll keep
everyone?
going. It looks like
Okay.
yeah, I'll keep going. I'm fine.
Okay, perfect.
How often do you see increased median nerve distal to the carpal tunnel? I've seen it a couple times. Both times it was somebody who had had some kind of other surgery on their hand. One was like he had had some like really bad trauma to his hand and he had a lot of bony abnormalities and he had already had a carpal tunnel release, but he still had symptoms and he had this big bone spur that was kind of pushing up into it. So especially if you see it distal, you know, take some more time scanning into the palm and adjusting your settings if you see that. But 99% of the time, it's going to be, going into carpal tunnel, getting big, and then it goes through, it gets more narrow. But if I see that kind of afterwards, it still looks really big, usually I'm going to scan more. I'm going to look to see if there's something odd structurally about this patient. What references do you use? So my machine actually has reference values from Mayo on it. But again, Wake Forest has some really nice ones too that are kind of readily available for the cross-sectional area stuff. If a patient has normal nerve conduction for CTS, but a large medial nerve ultrasound clinically, yeah, yeah, so you'll have this, right? When you're doing nerve conduction studies, we've all had that patient come in, my pinky gets numb when I hold my arm like this long enough, and it keeps happening and it wakes me up, and you swear you're like, that's ulnar at the elbow or something. And then you're doing it and you don't really see it, but the symptoms are intermittent. Or they come in and they're saying, I wake up at night, I gotta shake up my wrists, I hold on the steering wheel, they go numb, you tap, 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 they're getting numb and tingly, but you do your study and it's very normal. You do comparative values and it's normal. There is a good paper that came out, I think Michael Cartwright was on it, about patients who very much clinically had carpal tunnel syndrome. Their nerve conduction study was not diagnostic. Adding ultrasound, did you increase sensitivity? And then if those patients were treated, they did better. It increased it by like 20%. Because nerve conduction study in EMG is not 100%, even especially when it comes to radiculopathy, depending on who you go, they say 60 to 80%. You still have a raging S1 and your nerve and muscle test is normal. Can it be helpful for the facial nerve? Yeah, you can see the facial nerve in the parotid gland, and then you can look at the musculature, and there are courses where you can like look at other little nerves in the head and the neck too. Um, especially if someone is coming in. I had one patient who, came in for facial weakness and it's progressive, and you're kind of looking at the one side of their face that's bigger, and I don't know really how to look at glandular tissue. But I threw the ultrasound on and I was like, I'm just gonna get a picture of, a CT scan of your glands because they had a parotid tumor. So it can just help kind of increase confidence in that way. And again, there are like courses and stuff, and there is more things coming about the facial nerves themselves using kind of like higher frequency probes and even looking at the musculature of the face. Uses of NEMUS for in piriformis syndrome. I think probably the best use right now would be for guidance of a treatment. Piriformis syndrome is one of those things, right, that it comes in the lab and you're like, oh, am I really going to try to do the thing where I put their knee in Faber and do the H reflex one way or the other? And then people argue about that. And then invariably you do the study and you don't really find too much. And even if you try to needle deep in the gluteal muscle, you're like, well, am I really even in the piriformis? And what does that even matter? Because pronator teres syndrome, the pronator teres is normal. So I think probably the best use right now, and if I'm seeing somebody for piriformis syndrome, I'm sending them pain management. I want them to inject it. I want them to inject there. And if they get a lot better and all their symptoms go away, then that's kind of what it is. So that's what it probably is best for right now. In an EMG plus test, how can we properly place the electrode in order to get a particular test? A lot of times sensitive to current fixation of the electrodes. I'm not sure what EMG plus test is. Best practice procedures cause. I don't know if this is talking about like putting the probably place the electrode. Sometimes sensitive current fixation. So I don't really use it to decide where I'm going to put my kind of like disc electrodes or sticky electrodes. I suppose if you kind of had a big person and you really wanted to know where the middle, if you're doing like a big muscle like a deltoid, or you're doing a musculocutaneous, but they're pretty big, so usually kind of what you're doing. I don't know if it would add so much help for that. It can be helpful if they have a big arm and I want to know if I'm really poking the muscle that I am, or if it's in the big forearm and you're using a longer needle and you're wondering, am I really in the flexor carpi radialis, or could be in the ulnaris, or am I just in the subliminus? Am I really at the flexor pollicis longus muscle? Did I really get deep enough? You see, you go and you hit the bone, you pull back. Some people get nervous, arteries running in there, give them a big bruise. So more probably for if it's a atypical muscle you don't test and you really want to know you're deep in the right spot, I think it would be more helpful. I'm unaware if it'd really be too helpful for placing your electrodes to measure for your nerve conduction studies. Could NEMUS used to evaluate the pudendal nerve? I'm unaware of it being used to evaluate for the pudendal nerve. I wonder if that would be better accomplished by something like a transvaginal ultrasound, which obviously wouldn't be done by most people who are here. But I suppose, that's probably an area where research could be done if it's not. I'm sure it could probably, if you can get things right and you can get a probe in the right patient, because again, it's the deeper it is and the more tissue you go through, it gets harder to see. But the probes and the technology keeps getting better and better. What's your experience with chronic Guyon's tunnel syndromes? I think it is really helpful. I really like it. You know, so many times you do ulnar motor studies, maybe an older patient, you end up, most people's normative data goes up to like 65, 70, and then everybody's kind of lumped in after that, right? Everybody's the same. So you have an 89-year-old come in and you're like, well, what is normal for this patient? And invariably you're like, oh, the ulnar motor response is a little long. Is it really entrapped there? Is it really abnormal? Should I just enhance my waveforms and be like, oh, a little off the motor point? And then you're kind of futzing and trying to make it within your range of normal. That really isn't even for that age group. I think it is quite good at seeing enlargement about Guyon's canal or afterwards. So I quite like it for that. And they have the little hockey stick probe that's a little tinier. That's nice for kind of maneuvering right around there because it's really easy to get the ulnar nerve there next to the artery and then the pisiform bone, and you kind of move it up and down. So I quite like it for that. Or somebody has an obvious elbow and then the distal latency is a little off and you're like, is this a double crunch? I kind of like the ultrasound to be more confident in that. EMG plus. If you could speak a little about it, EMG plus test, it would be very helpful. I'm really not sure what EMG plus test means, if I'm honest.
It is our EMG software. So you can do
Oh, okay.
EMG or EMG plus, and
Oh,
they're talking about,
is that with all that kind of like quantitative, right?
yes.
Okay, so that's quantitative EMG. Um, So, the quantitative EMG is kind of fun. It even has that feature in it where you can have them push and push a little more, and it'll tell you kind of, is you going more myopathic or more neuropathic? Um, I guess it depends on what you're using the ultrasound for, because again, the needle examination is almost like an electrical biopsy of muscle, right? You're sticking it in, you're measuring these motor unit action potentials. That's kind of physiologic information, whereas the ultrasound is more structural. So again, I would like to know them together. It would be very helpful if you look at a muscle and you say, wow, that ecotexture is really abnormal, that muscle's abnormal, and you poke it in a couple spots and it's very neurogenic. And then you're very sure that that's probably a neurogenic change. So I really think they go together, and quantitative EMG could kind of be its own thing, but it is very exciting with the technology and it's kind of fun to use it. What are the mechanisms undergirding cross-sectional? My best way to explain this easily is, the axonoplasmic flow for your nerve comes from the cell body, and all the cell bodies are up at the spinal cord. So if I pinch and I cause a roadblock, things are going to get backed up behind that. I think that's the best way to describe kind of the swelling. I think it has to do with axonoplasmic transport and flow, and literally things are backed up behind it. If you cause very bad pressure, you could cause like ischemic injury and like even nerve infarct, but then you get axon loss. But I think that's the best way to kind of think about that increase in cross-sectional area. Same thing if they have like CIDP or another autoimmune inflammatory neuropathy with demyelinating characteristics, their nerve tends to get bigger and swollen because of the inflammation, which just makes sense here. Oh yeah, tumor, rubor, pallor, the old stuff that you think about that still kind of fits in with anything new that comes out. They'll kind of grow and get bigger. What do you experience intervention like steroid infiltration? So most people use it for guidance. So, if you're going to start with that, I tend to not get into that too much just because of how my practice is built. But a lot of people like it, maybe they come in, they find the carpal tunnel, they see it and they say, okay, I'm going to give you a steroid shot now, if you're okay with it, and we'll see if it helps. You can really kind of use it to see your nerve and be sure that when you're like hydrodissecting your infiltration of steroids in, that it's going around the nerve. And you can see that I am by the median nerve and I've hydrodissected and this nerve has now kind of been surrounded or abutted by my steroid. If you do a blind injection, sometimes, even with nerve conductions, you're a little surprised. You're kind of at the wrist and you're like, the median nerve should be here. And then you kind of walk, a centimeter or two over and you're like, oh, it's all the way over here. That's kind of a surprise to me. Ultrasound can help you just be sure that you are injecting where you want to inject, because they could fail an injection if you missed. Do you print images of ultrasound on your reports? It does not seem to be distinct as images on the instruments. Do you provide USB images to produce for others? So we are transitioning, and I am gonna start putting that into the reports. They're all kind of saved and banked right now, so I give them a Word document. But I think it is best to at least have like a key picture or two in the report. Or sometimes, like if I know the local surgeon who sent them in, I will actually through the university email, like send them the pictures and be like, hey, here's your patient. Especially if it's like regular carpal tunnel, maybe not, but like that patient who had the ganglion cyst at their elbow, I was like, hey, I'm sending this to you because this wouldn't be a simple surgery, and I want to make sure that they kind of know, okay, that's where it is, and that's what I'm kind of dealing with. It is recommended, and I think in the future, more and more, like if you want to build that full neuromuscular ultrasound one, they do want you to have images and then record things called CNAs, which are just cinema, little 10-second clips of the nerve around areas of entrapment as well, which you can do. Would you consider performing ultrasound before nerve conduction studies? Yeah, it depends. Again, a lot of times if it's like a kid, sometimes I'll start with that because it's a little fun, or you get someone who's just so nervous and they're coming in and your quick bedside exam is like kind of very focal. Sometimes I say, well, why don't we start with this? And it kind of helps them relax. Most of the time, my workflow is technician is going in, doing the nerve conductions after we decided on the study, EMG, and then ultrasound afterwards. If it's motor nerve disease, I tend to like to kind of use it to pick my muscles. So it depends on the case. For kids, I like it. Okay. I think that's everything.
Wonderful. Thank you, Dr. Smith, for all of your
Mm.
time today. I just want to give a couple of reminders. The webinars and the events that we have coming up are on the Cadwell website. Make sure you visit the website for those event announcements. Also, we will have this webinar available here in a few weeks on the Cadwell website for everyone's use as well. So keep that in mind. If you had to, if you know somebody that had to miss today, tell them it will be available to them later.
Oh, it said there's another question. It says, please PLS about my last question. Oh boy. I have to scroll up. Oh, piriformis syndrome. Yeah, I think it's helpful for, guiding the injection. If you really want to needle a piriformis or needle some of those deeper gluteal muscles, I think it's quite helpful to be more confident. Otherwise, you're like, am I really where I want to be? What muscle am I really even in? And thank you, Ali Batar, for saying thank you. I appreciate that.
Well, thank you everyone for attending today. We hope to see you at future events. Dr. Smith, brilliant as always.
Thank you. It was a pleasure, everybody. Have a good weekend.
Have a good weekend. Thank you.